OpenVPN, connecting your world securely. We believe all people should have unfiltered access to the internet. This will strengthen our society and provide people with equal opportunities. Our mission is to connect your world securely by providing a more safe and secure online experience. OpenVPN is the provider of next-gen secure and scalable communication services. Our award-winning open-source VPN protocol is the de facto standard in the open-source networking space with over 50 million downloads. Visit www.openvpn.net to use our consumer VPN private tunnel or our business VPN solution, Access Server.
Hello, my name is Rebecca Simon. On behalf of Shamiram Media, I welcome our viewers. Our guest today is Dr. Youssef Tahiri. Dr. Tahiri was born in Casablanca, Morocco in 1985. He is one of the only three plastic surgeons in the world who do the procedure and a technique called MEDPOR, which is a technique used to reconstruct ear on patients with a rare genetic disease called Microtia. Dr. Tahiri completed his medical school and residency at the McGill University in Montreal, Canada. He then got his master's degree in experimental surgery before moving to the United States for a fellowship in pediatric and adult craniofacial surgery at one of the leading children's hospitals, the Children's Hospital of Philadelphia, and the prestigious University of Pennsylvania. He then worked for a number of years at the Indiana University and other hospitals before being handpicked, trained, and discovered by Dr. John Rheinische, who is the founder of the technique MEDPOR. Dr. Tahiri and Dr. Rheinische, now his partner, practice plastic surgery in Beverly Hills, California. Dr. Tahiri, welcome.
Thank you, Rebecca.
And
nice
thank you very much for joining us.
Thank you for having me, Rebecca. Appreciate it.
Growing up in Casablanca, did you ever think that someday you will be one of the world's leading plastic surgeons in ear reconstruction?
Well, thank you for the kind words. And honestly, I think growing up, I never thought I would end up even being a physician or even being in the US or being in this position where I can help as many kids as I can. I think, in Morocco, where the French culture is very present, a lot of, and in the society where I live, particularly a lot of people, a lot of kids end up doing their studies in France. A lot of kids end up studying engineering or mathematics or commerce in France at some of the big universities and then go back to Morocco to work in the big firms. I think, growing up, that's what I always thought I would do. A lot of my family members, well, actually most of my family members did that. So that was in my mind, the original plan. I think things worked out progressively just like this, really. Just one step at a time, things happened, and I feel very blessed for that.
You come from a family, your father is an engineer.
Yeah.
Your mother is a doctor. What kind of a doctor is she?
She's an epidemiologist. So she was teaching at the University of Casablanca, the Faculty of Medicine, and yeah.
And you are the middle child of 3 children, and your siblings are also doctors.
Correct. My brother is finished his general surgery residency at McGill, and now he's doing his fellowship in thoracic surgery at the University of Toronto. And my sister is a psychologist.
And so the profession of medicine wasn't in the picture for you as you were growing up in Morocco. You wanted to be an engineer initially, but you ended up doing something else. Mm-hmm. Tell us what happened when you were 15.
I think, historically, I was good at math and physics. then all the good students in Morocco, they go to very few hand-picked schools in France. So there's HEC Paris, Polytechnique, Centrale. So it was the right thing to do for the best students is to do those schools. So at that time, you know, when you're like 14, 15, you don't really know what you want. You just think, okay, I'm going to do what is the most, you know, attractive, because you're just a kid, you don't know. And then I moved to Montreal. We got the grades to either go to medicine or go back to France. And you know, my mom had a very strong influence on me, and she really encouraged me to do medicine. And at that time, to be in all honesty, I just followed what she suggested. I wasn't sure yet, but again, I was just a kid, and the love for medicine really grew progressively over time.
And you also had another passion before having the passion for medicine, and that was soccer.
Correct. Yeah.
And so you hoped that you wanted to be a soccer player.
Yeah, I think it was a dream. Is, you know, every kid, soccer is so present in Morocco, and every kid that plays soccer, their dream is to be a soccer player. I think I played soccer, you know, very regularly, competitively, and I always wanted to become a soccer player. But
what happened?
I think I was better at medicine than soccer.
All right. So now you're in the McGill University,
yeah.
And you go to medical school. How did you find out that you wanted to do surgery?
It's a very good question. So when I got into medicine, I knew I was very good with my hands. And now in medicine, there's usually two tracks of people. People that are going to the surgical specialties, and then people that are going to the medical specialties, in my mind, and that's my personal opinion. I think the more cerebral people, they like to go into the medical specialties, versus the more hands-on, action-driven people, they go more into the surgical specialties. So I knew I wanted to work with my hands. I wanted to become a surgeon. And initially, early in my years, I wanted to become a cardiac surgeon, actually. But then I did on my third year of medical school, I did the rotation in plastic surgery, and I completely fell in love. Completely.
Interesting. And also, you finished high school at the age of 16.
Correct.
Quite young.
Correct.
And another roadblock that you overcame was the language barrier.
Yeah, big time.
You grew up speaking French and
Correct.
Moroccan.
Yeah.
And a little bit of Spanish.
Yeah.
And then you go to McGill, and what happens there?
That's, I think, one of the biggest challenges in my studies were after high school, I was accepted at McGill, which is an English university, and then University of Montreal, which was a French university. But McGill was, in my mind at that time, a better university, so I chose McGill, honestly, without speaking one word of English. So
you did not speak a
word of English, yeah. Because in Montreal, it's a francophone city, so people spoke French and English, but you got away with just speaking French. But I remember the first few months were really challenging. It was really challenging. I went from being such a top student to really struggling the first few months. But then things, you know, with perseverance, things got better. But the first few months were really challenging with the language.
Determination?
It was a good experience. Let's put it this way.
So how long did it take you to learn English well enough so you would not be challenged studying in medical school?
So after high school, then I went to pre-med, but at McGill the pre-med requirement to continue to go into medical school was having a GPA of 3.9 out of 4. So I had no choice of having the first few months to learn English. Otherwise, you would not get into you would not pursue your years in medical school. So it literally just took a few months. I would not say I spoke English fluently, but I would say I spoke enough English to pass my classes.
Very well. And then you went on to get your master's in
experimental surgery.
Experimental surgery. What is exactly that?
So what I did on my fourth year of medical school, I was applying to plastic surgery. Plastic surgery is a very competitive program to get in Canada. At that time in
the United States as well.
Correct. And in Canada at that time there were 19 spots. So if you
in the whole
country, and the year I applied, 19
spots for plastic surgery.
Correct, 1 spot at McGill. So when you look at it statistically, you're less likely to match into plastic surgery than matching. So what I decided to do on my 4th year of medical school, because the 4th year of medical school is relatively light. By then I spoke English perfectly, and so I decided to start a master's degree. And in experimental surgery, where I look at outcome of breast reconstruction after cancer. So I did a lot of outcome studies. I used the skills of my mom in epidemiology that she transmitted, and I did that, looked at outcomes by looking at how different technique of breast reconstruction after cancer affect the final outcomes. So I did that on my 4th year of medical school, and then I got accepted into plastic surgery. So what I did, I kept doing the master's part-time at night while studying residency.
What brought you to the United States to do a fellowship here? Why didn't you stay in Canada?
That's a very good question. After my training at McGill, so most of the really great fellowship in plastic surgery are in the US. And in craniofacial surgery, the top 2 fellowships were University of Pennsylvania, that was number 1, and then University of Washington University in Seattle. So really to pursue my dream of being a craniofacial surgeon, I needed to subspecialize, and I think doing it in one of those schools was the right call. So my plan was actually, Rebecca, to do my fellowship at UPenn and then go back to Canada. Truly, that was the plan. I had a job in Montreal already lined up, and I literally had just a visa for a year to come to the US that the UPenn sponsored me, and then I was going to go back to Canada.
And then?
And then one thing led to the other. I took a job in Indiana for a few years, and then one thing led to the other. I took a job here. I was even when I moved to University of Pennsylvania, to Philly, you would have told me I would end up in LA. I would have said, no way.
You're telling me that you, Youssef, have been consistently surprised in your life. Things have happened to you that you have not planned them. That's an interesting life to lead.
Absolutely. I would say that, the majority of things that happened to me were not planned.
Now, how did you meet Dr. John Rheinische, who came up about how many years ago? 30 years ago?
Exactly 30 years ago.
With the MEDPOR technique.
Correct.
Of reconstructing
ears. Correct.
How did you meet him?
So in 2014, I was a faculty at Indiana University, and there's this really good society called a conference called the American Association for Plastic Surgeons. Very competitive, very prestigious, and they select 4 doctors across the U.S. in the field of craniofacial surgery to give a talk for half an hour. So that year in 2014 was in Miami. I was in faculty at Indiana University. I was presenting on jaw distraction for babies that are born with a very small jaw and have trouble breathing. And so I was presenting on that. It's called the treatment of Pierrot band sequence. And then Dr. Rheinische was presenting right after me on ear reconstruction using the MEDPOR technique. At that time, I was doing a different technique for ear reconstruction, and my outcomes were like the rest of the country. But when he presented his paper, his outcomes were incredibly good. So after his talk, thriving to offer better outcomes to my patient, I went to talk to him and said, congratulations, those are incredible outcomes. Can I come and visit you in LA and see how you do it, because I want to learn from you so I can offer it to my patients. That was no thinking I'm going to join him in LA. I was working well in Indiana. Another surprise. So then he said, yeah, please come over. So I ended up coming to LA I spent a few days here, observed him, and then we went for dinner. And his wife, who is lovely, her and I hit it pretty well because she spoke French. So, you know, and then we left it there. And then a year later, there was another meeting, the same meeting that was in Arizona. And we met again, and then we talked, and then we had lunch together. And then, yeah, and then again, nothing happened. And then a year later again, I was interviewed for a job at University of British Columbia in Vancouver. They tried to recruit me, and then one of their fellow there knew Dr. Rheinische. And then she called Dr. Rheinische and said, hey, do you know Dr. Tahiri? He's interviewing for the craniofacial job here in Vancouver. And then he said, oh, I'm surprised. I didn't know he was looking for a job. And then she said, well, he's not looking for a job, but the university is trying to recruit him. He said, oh, okay. And then so he contacted me after. He said, hey, would you come to Los Angeles if I offer you a job and you come and join my practice? And you know, honestly, at that time, I realized everything that happened in my life was like unexpected and unplanned. And the way I take my decisions are, what is the worst case scenario? What's the worst thing that can happen? I would come to LA. If it works out, it's going to be great. And if it doesn't work out, it will be an incredible experience. You know, when you have diplomas, I feel when you have your diplomas in your pocket, when you're confident with your skills, you can bounce back. You know, that's how I feel. So I felt, what's the worst case scenario? I mean, there's definitely something to learn from him. Los Angeles is an incredible city. Why not? And then we talked for a few years, and that's how we made it happen.
Yeah, your highly trained skills are your passports to many opportunities.
I think that's what I tell people is really your skills, your diplomas. People can take everything from you, but they cannot take that, and you can bounce back anywhere you want.
Now, Youssef, prior to you being trained in MEDPOR technique by Dr. Rheinische, there were only 2 doctors
Correct.
in the world who performed this procedure. Dr. Rheinische, who is currently 75 years old,
Correct.
and another female doctor.
Dr. Lewin.
She's in her 50s.
Yeah.
You are the youngest of
Correct.
the group of 3.
Correct.
What did Dr. Rheinische, you believe, saw in you of all these plastic surgeons that he comes across, to determine that you are the one who will carry the torch in the future and continue with this amazing and very rare procedure that not every other doctor does? What did he see in you?
You know, I think one thing with doctors is, particularly doctors like Dr. Rheinische, who really committed his life to Microtia, to reconstruction. And I think for him, not only the outcomes is important, but the legacy of what he did is important. And not only that, I think also he operated on so many patients. When the time comes when he will be ready to retire, he will need someone that he trusts to take care of his patients. So I think what he saw in me is probably someone who technically can take care of his patients. So I think that was important. Someone who is passionate and someone who cares and honest. I think when you have someone who is passionate, who cares, who is honest and has integrity and has the skills to take care of your, I think that's what weighted on the balance and made it happen. I really care, and I want him to know that, you know, he knows that I care about his patients. So,
do you know if he was ever during this time looking for someone to train and pass on his technique, or you just came along and he said that's the one?
I think he was in his mind looking. I think at that time he was early 70s. Dr. Rheinische is in incredible shape. I think in his mind, he didn't actively look, but I think he knew in his mind that he would need someone to take care of his legacy. I think it just happened by chance.
Youssef, what is Microtia? If you can explain to our audience this rare genetic disease that strikes only in certain countries in the world, what is it and where does it happen?
Okay, so microtia, what it is, microtia means literally a small ear. What microtia is really is patients that are born with a very deformed ear or a complete absent ear. So the ear, they cannot hear from the ear, and the ear is very small. It looks like an ear remnant. We don't really know why it happens. There's no gene that was identified for microtia, but there are basically kids that are born without ears or very tiny ears compared to the other side. We see it more commonly in Asia. So the majority of our patients in our practice are mostly from Southeast Asia, Central Asia, Russia. We have few patients from Western Europe, and we have a lot of patients from South America and Latin America. So very common in Hispanics and very common in Asia.
A lot of the Assyrian population live in Iran, Iraq, Syria, Turkey, Lebanon. Have you had any patients from those areas?
I did. I actually did, and I do some Skypes and FaceTimes with patients from Iran. I don't know exactly from which community in Iran they are. I don't know if they're part of the Assyrian community or not, but I definitely have few patients from Iran. I think there's definitely that Asian genetic background in it. The only problem, I think, for political reasons, it's very hard for them to come to the US to get treated. But I definitely have patients from Iran.
Now, doctor, how do you treat someone with microtia? What is your procedure entail?
Strictly and technically, basically the patient is operating in Los Angeles, and it's a 6 to 8 hour surgery under anesthesia, where we will reconstruct the absent ear and base that reconstruction on the other side. And we use a special implant called the MEDPOR implant or polyethylene implant. The MEDPOR is the trade name, and then we sculpt the implant, or we do a 3D copy of the implant based on the other ear, and then that's going to be the skeleton of the ear reconstruction. And then we use a flap from inside the scalp to cover the implant, and then we use a combination of skin grafts, skin flaps to reconstruct the ear. The goal is to restore craniofacial balance. To me, the way I see it, and obviously for Dr. Rheinische the same, is microtia reconstruction is a very challenging procedure. But the way we want to see it, us as expert in this, is it's not because it's challenging that we cannot provide a really good outcome. So in our practice, we really set it almost like a cosmetic procedure. If someone gets a rhinoplasty or breast augmentation or breast surgery, you want it to be perfect. It's an elective. So for us, compared to a lot of other surgeons, for us, the ear reconstruction, we consider a cosmetic procedure where we want it to be perfect and restore craniofacial balance.
You mentioned that you take the skin and cover the ear and the implant. Where do you get the skin from?
So they already have some skin in the area where the ear is missing, so we will reuse that skin. Then sometimes we will take skin from the other side of the ear, from the other side behind the other ear, because the color is matching, and then we take some skin from the groin. If the patient has microtia on both sides, which could happen on both sides, correct, then we will take skin from the inner part of the arm. And the reason why, because the color is nice, and then you can hide the scars. The goal is to always hide the incisions.
And what do you do in cases where a child grows up and there's hair growing on the ears? What do you do with that? Have you had cases like that?
Using our technique, we're lucky we don't have hair growing from the skin, from the ear. There are the other most common technique, which is ear cartilage reconstruction. That's one of the big problem, is the patients, in that technique, they take rib cartilage and they sculpt an ear, and then they put it under the skin. However, in patients that have a low hairline, sometimes the ear can get covered with hair. with our technique, because we use skin grafts to cover the ear, we're actually very lucky that we don't have hair growing out from ears.
When a child grows up, do they have enough ear sensitivity to, for instance, be musicians?
Yeah, absolutely. Absolutely, they definitely do. Actually, there are a few musicians that have microtia. One of the singer of the band Kiss has actually microtia.
How interesting.
Yeah, I don't know his name because, but I know that because actually he helped Dr. Rheinische in the old days raise funds for patients with microtia. So one of the group member musician. There's another singer from Brazil who has microtia. So I think they compensate by hearing better on the other side. Even Beethoven was deaf.
Was deaf.
Yeah, so he used, he used a metal piece connected to the piano so that the sound, well, he didn't have, but a lot of microtia patients are deaf. And the reason I'm talking about the Beethoven, we recreate the hearing with either recreating a canal or using a bone hearing aid. So Beethoven used a long metal stick connected to the piano so that he can hear. So, and he didn't have microtia, but he had deafness, and most of patients with microtia have deafness. And Beethoven was an incredible musician, so they can. I truly, for me, and I'm really passionate about this, and I tell my patients this is, the goal is for you to live a complete normal life. And I emphasize this to the parents from the child, when the child is born. Like often the parents, when the kid is born with microtia, they are very distressed because often the disease process is not identified on ultrasound. It's not like cleft lip and palate. A lot of microtia, the majority of microtia is actually missed on ultrasound. So the majority of the time the parents are born, the kid is born and the parents were not aware about it, and it's a big surprise. So I often talk to them early on because they found us on the internet, on social media. And the reason why I'm talking to this is the most important thing for me, and I tell this to the patients, is to the parents, is like you should treat the kid like a normal kid. He can have all his dreams become true. You know what I mean? So,
is there an age limit? By that age, you gotta work on the patients with microtia, or else it would be too late?
It's a very good question. The problem with microtia is also the hearing aspect. So the microtia has two aspects: the cosmetic of not having an ear, and then hearing aspect. So I think it's very important to try to restore hearing at an early age. So if you have one side microtia, it's called unilateral microtia, you hear from the other side, so it's less critical. But if you have bilateral microtia, you really want to try to help the kids with hearing aid. So when you have bilateral microtia, you want to address the hearing as early as possible, because if they don't hear, they cannot speak.
They will go deaf.
Yeah, they're deaf, but they go
deaf,
mute.
They go mute as well.
Yeah, in order to be able to speak, you have to be able to hear. The reason I'm telling you this, just this week, I operated on a 20-year-old female, super nice girl, but she's completely mute. She was mismanaged, bilateral microtia, and now it's a little too late. So in terms of age, I think it's important to address the hearing aspect at an early age. In terms of the ear reconstruction, you can do it anytime. My oldest patient is 61. She's from San Diego. But I think, it's not only deformity, but there is also something psychosocial about it. Kids go to school, they can get teased. So I personally like to do the surgery very early.
By what age?
Around 3.5, but definitely before 5 years of age, because that's before they go to school. And so then by the time they go to school, the ear looks fantastic. It doesn't look like they had an ear reconstruction, and they can live a life without any bullying.
And they will not be psychologically impacted.
Correct.
Doctor, what is the difference between a MEDPOR procedure technique and the other techniques that have been done and are being done by a vast majority of plastic surgeons?
You're asking very good questions. So the most common technique is called the rib cartilage reconstruction. It was described in 1959 by a surgeon named Tanzer. And so the technique was changed a little bit since 1959, but it's still similar. The basis of it is you have to take rib from the chest, and you take three pieces of rib through a surgery, and then you carve an ear, and then you slide the rib cartilage under the skin where the ear is supposed to be. So if your hairline is low, it's going to be covered by hair. That's the first step. Then you need a second surgery where you have to take more rib and then put it under the construct you created so that the ear sticks out. And then often you need a third surgery to reconstruct the tragus, which is this part here. So the rib cartilage, the way I'm going to, to me it's an invasive procedure because you have to harvest ribs. But in order to have enough ribs, the kids have to be at least 10 years of age to have their surgery. So unfortunately, this surgery is usually done at around 9, 10, 11, or 12 years of age because you have to have a kid big enough to take rib. So it's a surgery that to me is delayed. It's very invasive because you have to take ribs. I had my ribs broken, and it's extremely painful for a few weeks. So you can imagine if someone takes away ribs from you. So you have to take ribs, so it's a painful procedure. It requires a hospitalization. So the patients usually have to stay in the hospital for 4 to 5 days after the surgery. And it's a multi-step procedure. So you need usually 3 surgeries. When you compare, and the problem is I truly believe, and it's not to throw shade at anybody, but I truly believe the results are not optimal. They don't look good. And if you go online or if you go speak, they're just not, to me, I don't think they're optimal according to my standards. I have done this procedure.
Yourself?
Yeah, I have done this procedure when I was in Indiana. Correct. Mm-hmm. And the reason why I reached out initially to Dr. Rheinische because I didn't think that they were good enough. And if I had a kid, I would not make him go through this. The MEDPOR technique is 1 surgery. It's done as an outpatient, so the patient goes home right after the surgery.
Amazing.
And you can do it at an early age. It's relatively pain-free.
Less speech therapy when it's done young.
Correct.
Versus a 10-year-old
Correct.
who has to go through speech
Correct.
therapy.
So it's an easier procedure for the patient. It's an easier procedure for the parents. It's less time-consuming, less hospitalizations, less traumatic for the kid, and you can do it at an early age. And ultimately, importantly, is the ear will look good. So to me, there is no brainer. So why do most people do the other procedure? For a few reasons. First is training. The MEDPOR ear reconstruction is a very challenging surgery. You need a lot of training, and it's an unforgiving surgery. If you have complications, things don't go well, and there's not much leeway to manage your complications. Versus cartilage, because you're using the body's own tissue, even when you have complications, it's more forgiving. Yes, the ear is not going to look good, but at least it's more forgiving. With the MEDPOR ear reconstruction, it's less forgiving. So then you would ask me, well, how come you guys have more training than the others? And the answer is, Microtia is rare. So if you live in this city, you won't get many patients. For us, because we have patients coming from all over the world, we do them on a very regular basis. So we do 3 or 4 a week. So by doing those, then you become much better at it. If you're a surgeon doing 4 or 5 a year, you're never going to be good at it. You know what I mean? Not because of your technical skills, it's because of repetition. I always say repetition is the mother of learning. If you keep doing something and you're doing over and over again, I think you will become better at it.
Are you being approached by doctors who use these other techniques saying, can you teach us the MEDPOR? We'd like to join your team. Instead of having 3 in the world who do this, we'd like to do it too because we believe in your procedure.
We do. We have regularly surgeons from all over the world coming to observe our procedure. And because they see our results and they want to see it for real, the only thing is it's hard for them then to go back and implement it. And the reason why, because even if you come and observe us for 2 weeks, it's not enough. It's just not enough. When I started here, I was already in attending, I was already a surgeon, and I spent the first 6 months just training every day. Every day I kept redoing the same thing over and over again. So, you know, even when we have doctor coming to observe us, I don't think that coming for a week or a month is enough, because first of all, they cannot scrub in, they cannot be in surgery hands-on. So then there is a big moral dilemma, because then you have surgeons coming to observe you. They think they observe you and you do it well and fast, so they think it's relatively easy. Then they go back home and they try to do it, and then they don't have the same outcomes. And I'm struggling with that, to be honest with you. I'm really struggling with that, because every time you would allow a surgeon to come and visit you, you want to spread the knowledge. But then I think a lot of times they think it's pretty straightforward, because we have a system, we have the same team, the same nurses, the same surgical techs, so we make it look easy. But then ultimately, what is the price to pay? You know, are the kids I don't want the kids to get hurt.
I understand. Doctor, you're saying that Microtia is a very rare genetic disease. What do you mean by rare? How often does it happen in the population?
So it's approximately around 1 in 12,000, 1 in 15,000, approximately.
In the world, or in that region in specific?
In the world.
In the world.
So it's probably, it's funny you're saying this. So yes, you're right. So we don't really know the exact number. So it's probably much more common in Southeast Asia and South America than Africa. When you put all the numbers together, so it's 1 in 12,000, 1 in 15,000.
You mentioned that we really don't know why microtia happens in children. Are there any research being done, or what could be the causation of this condition?
There are a few hypotheses. There's currently a research study looking at genetics. So we're trying to get genetic samples, saliva samples from all patients to try. We don't have results yet. But there are some hypotheses about, there's a small vessel, a small artery called the stapedial artery, that they say may be bleeding during when the baby is a fetus, and that can cause problems with the ear. But there is no real, right now we don't have a proper reason on why it's caused. We know there is some genetic component to it, because of just the geographics of it. Like, it's more common in Southeast Asia and South America. I mean, the majority of my patients are Chinese, Russian, Southeast Asian, and Hispanics. So I know it's more common in this area, so there must be something genetic. However, we have many patients that have identical twins, and their twin sibling does not have microtia. So identical twins, meaning they share the same DNA, the same genetics. And one of them has it and one of them does not have it. So you wonder, is it genetic or not? If you think about it, 2 identical twins and one has a disease and the other one does not, then you would think it's not genetic.
There are other factors involved.
There is definitely something, they call it epigenetic.
Now, is this passed on from parents to children, grandchildren?
It's not. I'm not giving you any concrete answer. It's not. We don't know yet. Sorry, looks like I don't know anything. We don't know yet. But it's rare to see a dad or mom with microtia and then a son with microtia. However, if you dig into their history, you would see maybe the dad or the mom will have a little abnormality in the ear. You would see, I have a distant uncle that has microtia, or like, they had a smaller ear. He had a cousin that has a smaller ear. So I think, so there is definitely something familial and genetic. But it's rare to see someone exactly within the family, direct family members with microtia.
Does it affect females or males more? Do we know that?
A tiny bit more males than females, and we don't know why. We don't know a lot of things, but we know how to fix it.
We know how to fix it. That's more important.
We don't know exactly, and we're still looking for it, but we know how to fix it well.
How long more Dr. Rheinische is planning on operating? Because once he retires, there's going to be just two of you.
Yeah, I hope he goes on for many, many years. I really wish him a lot of health. I don't know. I think he devoted his life to this, and I think that's his life. So as long as he's healthy, he's going to keep doing it.
Doctor, how can people contact you if they know someone with microtia, or some people just don't like the way their ears look like you? I'm sure you can do that. It's a much simpler operation. How can they contact you?
Usually, we have two websites. Either TahiriPlasticSurgery.com or MicrotiaRepair.com, and then they can go on, and then there's a little format, and they can just email us. They can upload pictures. That's how the majority of our patients contact us. A lot of patients also contact us via Instagram. They will send us a direct message to our account, and we try to respond. We have a lot of patient coordinators in our office that speak different languages. Because of the nature of our practice, we have Russian-speaking coordinator, Chinese-speaking coordinator, Spanish-speaking coordinator. I'm the French coordinator.
What about a Moroccan coordinator?
I'm also a Moroccan coordinator, and I think either Instagram or websites, we try to be pretty good at answering those.
You also travel all over the world, giving lectures.
Correct.
To the areas where microtia happens more often, and that's how you spread the word that there's this technique that is more successful, less intrusive.
Correct.
And so you get a number of patients that way.
Correct.
As well.
Yeah. I think, prior to COVID, and hopefully after the situations get resolved, we travel a lot. So we do three trips to China a year, one trip to Russia, one trip to Western Europe, one trip to Mexico, and one trip to South America every year. And our ultimate goal is to try to spread awareness about what we do. I always tell my patients, my goal is to not try to convince you to go one way or the other. That's not my job. My job is to give you the tools and the information necessary for you to take the best decision for your kid. So what we do, we go all around those countries. We give lectures to parents. We talk to them about what we do. We show them results, and we often have patients already there. So we have patients that come in, and we do individual consultations. And then if they feel that's the best thing for their kid, then they will fly to Los Angeles for their surgery.
As highly trained and gifted that you are,
I think just trained.
Yeah, okay.
Just trained and lucky and blessed.
You are a humble man.
Trained and blessed.
Do you do any other plastic surgeries in other areas of the face?
Yeah, body? Mostly. So I really try to focus on the majority of my practice is microtia, but as a craniofacial surgeon, I do a lot of. I still do facial surgeries. So anything that has to do with the face. I do a lot of skin cancers, skin cancer reconstruction, nasal work. Facial bone surgery. So I do a lot of these surgeries. Often the parents of the kids that I treat end up, having questions or things like this. And I work with the dermatology group in Los Angeles and take care of their skin cancers and all sorts of pediatric stuff. But the majority is really specialized in microtia. Now
tell me, are you happy that you didn't become an engineer or a soccer player?
I think it was the best decision in my life. I'm not happy. I think it was truly the best decision in my life. But as I said earlier, I think, and Steve Jobs said it well in his commencement speech in 2014 at the Stanford commencement speech. He's like, when you look forward, it's very hard to see why things happen. But when I look back, you can see all the dots align, and I think I could not be happier doing what I do.
So in hindsight,
yeah,
you're happy about your decisions.
Correct.
And that is wonderful.
Correct.
Youssef, I hope life isn't all work, travel for work for work. What do you do for fun?
Good question. So, I mean, first of all, I gotta tell you, it's work, but I really love what I do. So, is it fun? It is fun. So, what do I do for fun? I work because I truly deeply enjoy it. I know it sounds like a cheesy answer, but it is true. I truly enjoy doing it and helping kids, because when I see my post-ops and I see the kids smiling and the parents crying, it's the most fulfilling thing ever. So that's fun. Other things, I used to play a lot of soccer. Now I watch a lot of soccer, and I love surfing and skiing. Those are my two sports where I really connect with nature, connect with that's my meditation. Is I love to ski and I love to surf. Those are really, and being in LA, I'm blessed with both. So,
Dr. Youssef Tahiri, Casablanca gave us Humphrey Bogart and Ingrid Bergman classic, one of my favorite movies. And it has also given us a wonderful plastic surgeon.
Thank you so much. You're too kind.
Surgeon with subspecialty, and someone who is very passionate about what he does, has touched a lot of lives, not only patients' lives, but their families.
You're too kind.
So we thank you for that.
Thank you.
Thank you for joining us.
Thank you so much.
At
You're too kind.
Media.
Thank you, Rebecca. Thank you.
Our dear viewers, I hope that you have enjoyed our conversation today. And if you know of any Assyrian child or an adult who has microtia and is in need of help, please contact Shamiram Media and we might be able to help you. Thank you for your time. Good day.